Well, good afternoon, everybody. My name is Nick Hamilton from the Sports Engineering Research Group at the AWRC. I'll be chairing today's session. I'm just going to run through a few little housekeeping points while I wait for everybody else to join. But you are in the developing exercise interventions to optimise neurological rehabilitation seminar session, so welcome. Importantly, today's seminar is going to be recorded and it will be available on the AWRC YouTube channel in the next week or so, so do watch out for it. We'll let you know when it's live. Everyone's going to remain muted for the session other than the presenters to avoid any interruptions. So if you do want to ask any questions or make any points to the speakers, which we do encourage you to do, please use the chat functions we go through and we will run through the questions at the end. I'll collect those questions and give them to the presenters. We'll start in the next couple of minutes, so just hold tight before we get going. Okay, so let's make a start with this afternoon's session. So good afternoon and welcome to today's AWRC public seminar entitled Developing Exercise Interventions to Optimise Neurological Rehabilitation. As I said earlier, this session will be recorded, so please keep your cameras off if you don't want to be recorded. For anyone unfamiliar with the Advanced Wellbeing Research Centre, we're a world-leading research centre at Sheffield Hallam University that has a mission to transform lives through innovations that help people move. We are proudly based in the East End of Sheffield and located on the Sheffield Olympic Legacy Park. We bring communities, businesses and clinical services and public sector together with multidisciplinary academic expertise such as health, engineering, robotics, software design, psychology, sport and exercise science, and the arts to undertake world-leading research and innovation that helps people move. Our public seminar series runs every 2 months. This is actually the last seminar in the series. We're taking a break over the summer, but please do keep an eye on the AWRC website and Twitter, which is @SHU_AWRC, to keep up to date with all of our future sessions. So back to today's session. It's being hosted by one of our 5 research themes in neurological rehabilitation. This is headed up by Dr. Rachel Young. The AWRC's Neurological Rehabilitation Research Team integrates research, clinical provision, enterprise and education activities to progress the co-design, co-development and implementation of contemporary and effective technology enable rehabilitation interventions. These help to maximise life opportunities for people with neurological conditions and other long-term disabilities. Rachel will explain that much better than I have shortly. So for today's session, we're going to focus on developing exercise intervention which optimise neurological rehabilitation. Rachel is joined by a great lineup of speakers, Nik Kurdiersky and Dr. Anouska Carter. So over to Rachel, who will introduce their work and the speakers.
Good afternoon, everybody. I'm just in the process of sharing my screen. I'm sorry, I'm just having a little bit of an issue with my cursor, which was working fine a few minutes ago.
It was working fine when we practiced.
It was, wasn't it? Yeah, what's happened here? I do apologise. Hold on, I think we're good now. That's great. Is that visible to everybody?
Yeah, it's not. There you go. Perfect.
There we are. The technology always has us sweating briefly, doesn't it?
Thank you, Rachel.
Hold on. Just Okay, back to the first slide then. So thank you very much, Nick, for the introduction there. And thank you very much for all of our attendees this afternoon. Delighted to see so many people have taken the time to dial into our session and hear about some of the work that we've been doing within the neurological programme at the AWRC. My name's Rachel Young. I'm a chartered physiotherapist with 30 years of experience in neurological rehabilitation. It's been an absolute pleasure to work at the AWRC over the last 3 years and to take the opportunities that have been provided by such a broad interdisciplinary team of people who share the same passion for creating new innovations which help people to have better lives through more movement. And I'm particularly delighted this afternoon to be joined by Anouska and Nik, who are two dear colleagues to me and share that passion for neurological rehabilitation. So just a little bit about the programme. It was launched shortly after the AWRC opened in 2020. And we saw an opportunity to make the most of that interdisciplinary expertise at the AWRC to be able to work with therapists, exercise scientists, designers and engineers to build new technologies and test them, keeping the user's needs right at the centre of everything that we developed so that we can help people who are living with neurological impairments to move and have more independence. In the UK, 1 in 6 people live with a neurological impairment. And there are over 1 million people in the UK living with stroke, with 100,000 new strokes every year. So it's a very big area of practice, and a lot of people who live with neurological impairment will live with those changes for the rest of their lives. So finding ways to enable movement and improve outcomes is so important, and we've had a great opportunity to do that through the programme here at the AWRC. So just to give a taster of a few of the projects that have sat within the neurological programme, we've stretched across the laboratory and then out into the community as well. So the slide there on the left-hand side of this, or the picture on the left-hand side of this slide here today, shows the Magic 5 project, which was based in the Movement Analysis Lab at the AWRC. And you'll see there that we've got a participant sat on a power-assisted exercise machine. So this is a type of equipment where people sit into the machine and hold the foot plates and the handles and are actually assisted in movement. It's a great solution for people with neurological impairment who might have difficulty initiating movement or sustaining movement. And the aim of the Magic 5 project was really to measure the physical responses to power-assisted exercise. So we wanted to establish what the aerobic demand was, what the muscular responses were to this type of exercise. And that helped us to identify the benefits of each of the different machines which were tested, which included 12 in total. So this really strengthened our collaboration with Inerva, who are the manufacturers of this equipment, and has led on to future larger funded research projects. We've also got innovation at the centre of many of the projects, and in the middle you can see a picture of a balance platform, and this is a device which has been developed by a Sheffield company called Design, which enables people to explore the limits of their balance within the safety of that secured frame. And we're delighted to be working with the team again over the next few months to further advance this technology and introduce some smart components to it as well. But importantly is that we reach out into the community, to those people who are living with neurological impairments on a day-to-day basis, and try some of these new ideas, new technologies out with them to make sure that their feedback, their experience of these innovations is central to how we take them forwards. And in that final photograph, you can see somebody who's within their home environment. If you look closely, you can see that he's actually wearing a pair of inflatable trousers, if you like. And this was an innovation which helped someone with very limited mobility to stand up better and be able to take some more steps. You'll also see that the team around him are physiotherapy students, and at the AWRC we welcome students on placement into the centre to help us with that reach out into the community and to generate more data as well. So that's just a taster of a few of the projects which have been based within this neurological programme. So for today, we're starting off with a spotlight on stroke, and this is in response to the new clinical guideline for stroke, which was published in March. And we identified that We had a body of research generated within the programme that closely aligned with the content of these guidelines. So I'm going to talk about some of our qualitative data to start with, and then we'll be introducing Nik, who's done some work particularly with acute stroke and recumbent cycling. After that, we'll move on to Anouska, who will talk about multiple sclerosis and the benefits of exercise for people who live with multiple sclerosis, and the protocol for an exoskeleton project, which will be starting over the next couple of months. And finally, I will just conclude with an example of some of the co-design work that we've also done to exemplify how we use participants to help design and test some of our new ideas and technologies. So this new national clinical guideline for stroke was published in March 2023. It was an update from the one developed by the Royal College of Physicians back in 2016, and it sent a bit of a shockwave, I think, through the rehab community, not least because the quantity of therapy that's recommended within this guideline is greater than those previous recommendations. So we're looking at being able to deliver a minimum of 3 hours of multidisciplinary therapy a day for patients receiving rehabilitation for motor recovery. We're also looking at 6 active hours a day in rehabilitation as well. So the demand on inpatient services and community services has increased if we're going to achieve the quantity of therapy stipulated within this new guideline. Also, physical activity and exercise is more clearly stipulated within this new guideline as well, with recommendations for a programme of resistance training and moderate or high intensity aerobic training for people into the long-term living with stroke, to improve their long-term outcome and reduce the risk of secondary stroke. And what was particularly new and pertinent within this new guideline was that it recommended that facilities and equipment to support high-intensity cardiorespiratory fitness training, such as bodyweight support treadmills or recumbent cycles, should be available. So we're looking at increasing the number of facilities that are available, which are user-friendly for people with stroke, but also the availability of very specialist equipment. So those people who might have limited mobility, may have difficulty initiating movement, still have the opportunity to exercise at an appropriate intensity for them as well. So when we were wondering which studies to showcase within our seminar this afternoon, really it was this qualitative research which jumped out at me first, because I think the user's voice within these studies is really strong and resonates closely with the recommendations in the new clinical guideline for stroke. So I'm going to talk through the findings from a qualitative study we conducted with a local centre, and also a systematic review which we conducted as well, which focused upon qualitative data, all surrounding the experience of venue-based exercise for people with stroke. And whilst these studies might not have been particularly large in terms of the funding or the scale of the projects, I think the user's voice within this data is really powerful, and that's why we've selected these as a starter for today. So this first study was conducted at a local community stroke centre, and we aimed to really understand the experience of recovering from stroke and that transition from inpatient care out to the community and then into longer term care. So we recruited 8 adults who were living with stroke, 6 were female. 6 were male and 2 were female, and they ranged from being aged 42 up to being aged 76, so quite a diverse sample of people. You'll also notice on the right-hand column of this table, the functional ambulation category scores indicated that most of these people were living with quite limited mobility, so were unable to walk, for example, up and down stairs, unable to walk without assistance, or very dependent on a walking aid. So these are the types of people who've often been excluded from bigger studies on exercise for people with stroke. So we conducted in-depth semi-structured interviews with these participants, and we used interpretive methods to make sense of that data. So the interviews were quite long. They ranged from being 60 to 90 minutes long, and very much explored that journey from inpatient care through to longer term life with stroke. And what we found was that all of the participants recalled quite vividly the onset of stroke, and particularly their early experiences as an inpatient. The inpatient stay was recalled as a place where they felt safe and they felt cared for, but on the whole were rather sedentary. So there was limited activity, limited access to therapy within the hospital setting. And one participant recalled how he'd spent 2 hours one day trying to put his socks on himself and resisted repeated offers of help because he really just wanted to be able to put his socks on for himself and start to recover some independence and some empowerment over his own life. What also came through really strongly was how hard people found it at the end of their term of rehab. So I think they accepted that rehab had to be a finite process, that the NHS doesn't have an infinite resource to see people indefinitely. But they found that transition from having rehabilitation either in the community or as an outpatient, and the termination of that really challenging. And the quote in the bottom left box there sort of summarises how someone felt that they've been told that they were about to plateau, that they shouldn't expect any more recovery. And I think that's a conversation that we'd hope that we're not really having anymore with people with stroke, that potential to still have changes and still make recovery several years down the line should be there. But we need to support people in that transition from NHS into third sector care more effectively. They'd found that joining the centre had marked an upturn in terms of their physical and psychosocial well-being, that they enjoyed attending the centre, and they particularly enjoyed using the gym facilities there. So this is a centre which has a treadmill, it's got a recumbent bike, and then it's also got 6 pieces of power-assisted exercise equipment as well. And they liked using the equipment. They felt that the equipment had helped them to become stronger and to recover aspects of their mobility. So I think the experience of joining the centre was positive, but something that came out there, 4 of the participants had been signposted to the centre by their rehabilitation professionals, but 4 of the participants had actually found out about the centre incidentally, so it had been through word of mouth or by stumbling upon the place. So I think the signposting into the centre had been inconsistent. And finally, participants very much towards the end interview started to describe how they'd been able to reframe the experience of stroke that attended the centre was very much associated with recovery of confidence and feeling more like they were part of a community again. They also felt that for some people, they said, well, I didn't want to admit that I needed company. I didn't want to admit that I needed some psychosocial support. It was actually the exercise equipment which legitimised membership at the centre. But once I came to the centre, I recognised those broader benefits as well. And this quote at the bottom here was from a male participant who was 52 years old. And he described that he'd come out of his shell by coming to the centre, and that without the centre, it would have been, in his words, a big heartache, that he felt that he would have been stuck at home with nowhere else to go. So these findings were very similar to the findings of a systematic review, which also focused on the experience of venue-based exercise for people with stroke. And this was from a number of studies conducted across the UK, ranging from the southeast up to Edinburgh. So some more geographical diversity here. And we identified 7 studies which met the inclusion criteria. So in total, there were 76 participants, 48 of whom were male and 28 were female, ranging in terms of time since stroke from between 6 months to 13 years. The interventions which they'd been taking part in were exercise referral schemes or cardiac rehab programmes, or the ARNI programme, which is a stroke-specific exercise programme as well. So most of these interventions have been delivered in leisure centres, but most of them have been delivered by specialist stroke groups or specialist instructors. And some of the things that really came across in the data across these studies was that physical ability didn't appear to influence reported benefits. So some of the patients were unable to walk independently, whilst other participants were independently mobile and living with very mild, if any, motor impairment. And yet all of them reported similar benefits in terms of feeling stronger, feeling like they've recovered in terms of their psychosocial well-being as well. And participants particularly enjoyed the demedicalised experience of attending the leisure centre. So this bottom quote here saying, whatever you do, don't medicalise it. I think one of the key benefits of this is that it's not another appointment. You know, it's not the hospital, it's a community facility, and it makes other things feel accessible. So participants felt that because they'd coped with the leisure centre, they'd actually had a successful experience at the leisure centre, that it gave them the confidence to start to resume other community activities as well. So the limitations across these two qualitative studies included the fact that non-completers weren't included in data collection. So we only captured data from those people who'd completed the exercise programme or were still attending the centre. So there's a real gap in terms of understanding why people might drop out from exercise interventions or not uptake in the first place. In some ways, the geographical diversity of the projects was limited. So, for example, there was none from North England and none from the southwest of England either, or Wales. So it was mainly Edinburgh and Scotland, London, and then our local project in Sheffield. I would also say that certainly within the first project that I described, that there was limited cultural and socioeconomic diversity amongst the participants. And finally, for me as the lead researcher on these two projects, I would have to acknowledge my own bias in terms of my own beliefs that exercise and physical interventions are a good thing for people with neurological impairment. So to conclude, it was very much established that there are multiple benefits, self-reported benefits associated with exercise interventions and venue-based exercise for people with stroke, but that there are real inconsistencies in terms of how people are supported in that transition from NHS care into third sector or leisure sector providers. So we need to find ways to interconnect, to build that connectivity between our NHS rehabilitation therapists and our leisure service providers, but also that we need to build up the availability of assistive and accessible equipment in community and leisure venues. And I am aware that there's some examples of excellent practice out there. So it's a case of understanding what works and how we scale that up as well. So thank you very much for listening there. And I'll be delighted to hand over to Nik next, who's got a particular focus on the inpatient journey in stroke. Thank you for listening.
That's brilliant, Rachel. Thank you so much for that presentation. Just as a reminder, we are taking questions. There's a Q&A box at the bottom of your screen. So if you do have questions for Rachel or any of the other speakers as we go through, do use that to collate our questions, and we'll put those to the presenters at the end. So just while Nik's getting ready to share his presentation, we shall move on to him.
Hi everyone, can you see that okay? Great. Okay, hi everyone, my name is Nik Kurdiersky. I'm a researcher and PhD candidate. My background is in clinical exercise physiology. My research is focused on aerobic exercise training in acute stroke. Aerobic exercise training is well known for its benefits to longevity, reducing cardiovascular risk factors. But this particular research is focused on trying to enhance recovery in the very early post-stroke period. But in order to address that question as to whether exercise helps that recovery process, we need to conduct a feasibility study to see if it's actually achievable in the NHS. So I'd like to start by setting the scene with the scientific rationale which underpins the intervention. So following an ischemic stroke, the blood flow is cut off to a brain region, and the majority of irreversible cell death occurs in the first 24 hours. This isn't to scale, it's just to emphasize the key phases. This is followed by a surge in inflammation, and as that begins to subside, there's a gradual improvement in function or a reduction in impairment. There's also a period of an upregulation or an enhanced degree of neuroplasticity, which occurs in the first week. And this is essentially where the nervous system begins to rewire and adapt to the injured tissue. Typically, from up until recently, the time frame for this emergency treatment to remove the blood clot was between 4 and 6 hours post-stroke. And about 90% of individuals are not eligible for this treatment because they arrive at hospital too late. And there's very limited treatment options available after this very short time window. This research is focused on the acute phase, so between 1 and 7 days, leading into the early subacute phase, to see if aerobic exercise can interact with these recovery processes and potentially enhance or reduce the level of brain injury. So briefly touching on the animal literature. So when a stroke is induced in mice or rats, groups of mice, rodents, are separated into either a control group with no access to a running wheel or treadmill versus a group that have access to those facilities. When exercise is initiated within the first 24 to 48 hours, after 24 hours post-stroke, and then daily exercise is continued for between 7, 14 and up to 30 days post-stroke. Typically, there is a reduction in brain damage, an enhancement in perfusion, so a better blood supply to the ischemic region, an enhancement in neuroplasticity, so a more complex architecture a more complex neural architecture, and that's accompanied by an improvement in neurological function. And the leading theory for this improvement, this overarching overall improvement, is that exercise leads to an increase in blood flow to the brain, which enhances the delivery of oxygen, nutrients, the clearance of waste products, and the increase in neurotropic factors, which are proteins responsible for the survival and reorganization of the nervous system. So moving on to the feasibility work, this is the exercise bike that we used in the acute stroke ward. So this is a really unique device which enables people to cycle despite having a weakness on one side of the body. The cuffs underneath the calves prevent the knees from locking out, and it can be set into 2 modes, either passive, where the bike moves the person's leg for them, or active cycling, where it's the person driving the crank arms around. So we recruited people over the age of 18 between 2 and 7 days post ischemic stroke. So we're aiming for that really early period. They had to be medically stable, so they had a normal temperature, normal oxygen saturation, and no contraindications such as a recent heart attack, unstable diabetes, unstable blood pressure, and the ability to mobilize at least one leg. Even if there's very little strength in one of the legs, the stronger leg can help drive the other one round and keep it in a smooth motion, and they should still be able to perform a little bit of active muscle exertion even in the weaker leg. And then, of course, being able to provide informed consent, so being able to understand what the research entails and being able to communicate that. And occasionally we needed staff, a speech and language therapist to support that, or another healthcare professional. With the support of a PPI group, we designed accessible information, so a participant information sheet and a consent form, which we think is really important for this type of research for people with brain injuries and communication difficulties. So this is the exercise program. There are 5 sessions, and they increase by 5 minutes in duration. So the top line is the first exercise session. The blue phase represents passive cycling, where the bike is getting the legs moving for them. This is followed by a gradual warm-up. Then a 5-minute bout at moderate intensity, which I'll describe on the next slide. And these are interspersed with 1-minute passive recovery periods, and then followed by a gradual cool down, and then a passive period to prevent blood from pooling in the legs. And this was also designed with the support of the PPI group. So we used the rating of perceived exertion scale, which is a very simple, pragmatic tool, which is often used in cardiac and pulmonary rehabilitation. So we asked people to exercise at an intensity that they perceived somewhat hard, or another way of describing that is that it shouldn't be absolutely exhausting where they couldn't have a conversation, but it should feel a little bit challenging, so it's not a stroll in the park. As you can imagine, this was a bit quite difficult to get this across, especially if someone has not exercised in the past. So it took a couple of sessions to find what people to find an appropriate resistance on the bike at appropriate speed. So the feasibility outcomes that we're interested in is, could we recruit enough people? So if we were to take this to a larger scale trial, is it possible to recruit people within the allocated time frame? Is the intervention safe? How do participants tolerate it? So is it acceptable or not? How closely do people sit, or how closely is the exercise session how does it match the planned session? So can people complete the full session and the full program? And how does it interact with current practice? And can we collect enough data? So I'll just be sharing a few key outcomes from this study. So beginning with the recruitment, so recruited 30 participants across the 13 months, so 2.3 participants per month. It seemed, looking at those numbers, it does look quite slow, but it is roughly in line with what the literature kind of recommends, so between 1 and 2 participants per single site. Sorry. And then here's just an overview of the original group, so 15 in each group. There was an age difference, and that was because we used stroke severity as a stratification tool. So we wanted to ensure that people had a roughly similar stroke severity, which you can see with the NIHSS score. But unfortunately, it led to an older group for the control group. So it was an even split of males and females. And most people were unable to walk, so mostly bedbound or had to sit in a bedside chair. So firstly, we had no adverse events associated with the intervention, which I think is a really positive finding, and it will help give some reassurance that it's possible to do this type of exercise in the early acute phase. I conducted some interviews with participants, and all participants perceived the bike as comfortable. And as Rachel highlighted earlier, the stroke ward, or the hospital period, can be quite a sedentary and lonely place. But this, we had some really positive feedback. So it provided people with a sense of achievement and gave them something to work towards, so they were making progress, and really broke up the boredom, because a lot of people just sat around, and particularly during that period, it was during the COVID kind of lockdown, and people were felt really isolated. Some people felt very sharp afterwards. Other people felt absolutely wiped out and knackered. And there was differences in attitudes. So some people really enjoyed it. Others just felt like it's just something that you need to get on with and get it done. And after finishing the 5 sessions, others were a bit disappointed that there were only 5 sessions, and they still had quite a lengthy period in hospital. So they'd enjoyed it, but that had been taken away from them. And in general, a lot of people had a very selfless attitude that taking part in research would be really helpful to help, other future individuals that have a stroke. So that was really nice to see. Moving on to intervention fidelity. So there were 75 planned sessions, 55 delivered. They were delivered by myself, and 20 were missed. So the main reason for non-completion was that people were discharged early. That could have been back home or to a local rehabilitation centre. One person dropped out. They felt that the intervention was a bit overwhelming. One person developed a urinary tract infection, which wasn't related to the intervention, but they did develop a little bit of a temperature, so they were excluded due to taking antibiotics. And one person didn't want to complete a session because they felt fatigued from the previous session. I also conducted a mechanistic investigation to look at the blood flow or blood velocity response to exercise to help understand if what we've seen in the preclinical or animal literature matches up to what happens in individuals, in human participants. So just to go over the equipment that we used, it was a transcranial Doppler ultrasound. So a headset is placed on, and 2 probes are fitted around about the temporal region just in front of the ear, and we line it up to the middle cerebral artery. So this graph just looks at represents the change in cerebral blood velocity. So the orange represents the injured side of the brain, so the ipsilateral hemisphere, and the blue is the opposite side, so the non-injured part of the brain. And there's quite a consistent trend with both hemispheres that there is a roughly 10 to 15% increase in blood velocity throughout the exercise session. So again, it's really intriguing finding. We're not sure why it kind of drops off after between the second and third bout. There are a number of possible explanations, but overall, you can see it remains elevated even after the session is finished. So in summary, aerobic exercise training in the acute phase of stroke is safe and acceptable. People who are unable to walk unassisted can cycle at a moderate intensity for over 30 minutes, and cerebral blood velocity increases by about 10 to 15% during exercise. So we developed some more research questions as a result of this. So we want to know, is it feasible to conduct in other settings, so other hospitals or a secondary rehab centre? Can some participants cycle unsupervised if they're given the correct instructions and they feel confident enough to do that, which would free up some of the staff time? We need some more funding and time to be able to understand, does aerobic exercise affect the injured brain? So more sophisticated brain imaging would be necessary to do that. To understand what the optimal dose is, so maybe perhaps conduct a dose response study where people have shorter interventions versus longer term. And lastly, and probably the most important one, is what's the cost effectiveness of the intervention, because it would only be taken up by NHS commissioners if it's been shown to be overall cost effective. And lastly, just to say thank you to the supervisory team, all the staff members at the Hallamshire Hospital, the therapists, participants for dedicating their time and help, being selfless for helping other people. So thank you very much for listening, and I'll hand back over to Nik.
Thank you very much, Nik. That's great. Really interesting presentation. So just while Anouska's getting her slides ready, just a reminder again about that we're collating questions as we go through. So if you do have a question for any of the speakers, please do pop them into the Q&A box at the bottom, and we shall come to them in about 10 minutes' time. So Anouska, over to you.
Thanks, Nik.
Yeah, that was great.
Is that working? So it wasn't working earlier. I've got 2 screens and it was messing me about, so I'm glad that's working. So hi, and thanks. I've enjoyed listening to Rachel and Nik's presentations, so I hope you have too. We're going to change to a different condition now. So we're moving over on to multiple sclerosis and looking at a powered exoskeleton for assisting walking and helping improve cardiovascular fitness. And this is a feasibility trial. So this is a trial that we're just about to start, as Rachel mentioned earlier. So my name's Anouska Carter, and my background is in exercise and health physiology. And my background is in working predominantly with people with MS to use exercise to help them manage their symptoms and provide additional benefits. So you can see here, I won't name everyone because it'll take most of my presentation time, but there's quite a large team involved in this project across Sheffield Teaching Hospitals and the University of Sheffield, and also the Sheffield Neurophysiotherapy team who are delivering the exoskeleton intervention. So just an overview, I'm going to just provide a little update on what multiple sclerosis actually is for those of you that aren't familiar with the condition. We're then going to talk about physical activity, exercise and MS and why it's beneficial, and a little bit about how technology can help people with MS to exercise. I'm then going to look at the exoskeleton trial that we have planned and that is hopefully going to start shortly. So multiple sclerosis, it's an autoimmune condition that affects the brain and the spinal cord. And autoimmune means that the body attacks its own healthy cells. In the case of MS, this is the central nervous system. So you can see damage here to the myelin on a neuron affected by MS. And this means that it affects the messages that are getting through. So sometimes partially, it might slow down that message or distort it, or it might stop it completely. And depending on where in the central nervous system this has happened, what type of symptoms that person may have. MS is also fairly common. It's one of the most common neural conditions in young adults. So it affects people predominantly in their sort of 30s and 40s, and they have a near normal life expectancy as well. So management of symptoms and the condition is really crucial. So you can see some of the key symptoms that people with MS experience here. Some of the most commonly reported as being a problem are things like fatigue and pain, but the most common symptom is here, I think the second one on here is walking difficulty. So you can see where something like a powered exoskeleton could help people that are having difficulties with walking. So for many years, exercise wasn't recommended even for people with mild to moderate disability with MS. So historically, this was thought to be because of fatigue and the fact that exercise may obviously increase fatigue levels, and also because exercise can make you a little bit warmer, which tended to increase the symptoms of people with MS. But we now know that's temporary and it doesn't actually have any lasting problems. There's been a rapid increase in the research in exercise and MS over the last 20 to 30 years. And we do now know that exercise is safe and can improve fitness, fatigue and quality of life, particularly for people with mild to moderate disability. There's also really promising early evidence that suggests it may have a disease modifying effect as well. So really crucial to be part of the process in terms of managing the condition. There are also current exercise guidelines for people with mild to moderate MS. And these are fairly similar to the general population guidelines in terms of minutes of moderate intensity activity and also in terms of strength training. So I thought this diagram was worth showing just to highlight the importance of exercise in managing symptoms in multiple sclerosis. And this was from a fairly recent review that kind of highlights where it sits in that pathway. So obviously inactivity, you can see on the left, there's that kind of vicious cycle of deconditioning physiologically, which makes things worse, makes the symptoms worse, which leads to more physical inactivity and further deconditioning. And what you need to do is try and break that cycle. So the first line treatment for MS is obviously the disease modifying therapies, which can slow down the progression of the condition, but they don't treat the symptoms specifically. And although there are specific drugs for symptoms, they're not fully effective. So physical activity or exercise training can act as this really impactful sort of adjunct therapy to help people manage things like fatigue, mobility, balance, improve their fitness and their strength, and improve their quality of life as well. Also, importantly, decrease their risk of other comorbidities. So a lot of people, when they're inactive, obviously have an increased risk of things like cardiovascular disease, diabetes, osteoporosis from that sedentary lifestyle. So it's really important that we can support people to be active and reduce the risk of that as well. So for people with more severe disability or moderate to severe disability from MS, the exercise recommendations are a little bit more cautious. So this is an article by Kalb and colleagues in 2020. And as you can see, it suggests for those with more limited mobility, that exercise training should be facilitated by a trained specialist, and that safety and appropriate prescription is really important. But research in this group is more limited. There is research out there, but there isn't as much to recommend what is best for this group, how it should be done, how to support people to exercise more regularly. And there are increased barriers to participation. For example, with increased disability, you get increased issues with travelling somewhere to exercise or with using certain pieces of equipment. Physical inactivity and decondition are also more common in this group, particularly in people that are non-ambulatory. And there's been various research on technologies on how to increase activity for people with more severe disability from MS and help them to be able to benefit from being more active. So you can see here there's various different technologies that have been used in the research with people with MS. So you get things like the body weight supported treadmill, which I think Rachel mentioned earlier in stroke rehab, and that's been used for a while in exercise research for people with more severe disability. You've got VR here. You've got various apps that have been used, vibration plates, assisted exercise, and various things in the home, such as Wii Fits, Xboxes, etc. So this research is looking at a powered exoskeleton. And we know that walking is often cited as an effective means of exercise. And early exoskeleton research suggests improvements in walking ability from using an exoskeleton. Now, I've provided a picture here because a lot of people, whenever I've mentioned this project, have mentioned Wallace and Gromit, so I had to put a picture in of that. But actually an exoskeleton is a lot more user-friendly than a Wallace and Gromit, where the user actually has to initiate the movement and have control of that. And what we wanted to find out, because it's not clear how walking with a powered exoskeleton can benefit our health and fitness for people with MS. So the aims of this project were to determine the feasibility, acceptability and safety of the intervention, and to explore the level of exercise that people were able to achieve using the powered exoskeleton. And importantly, comparing that to standard exercise training using current guidelines. So it was a supervised training sessions within the gym environment. We had two groups. So as we just mentioned, 12 people in each, and they would be walking or working in the gym for 30 minutes, twice a week for 8 weeks. The outcome measures that we will be looking at, we have primary outcome measures that are around, can we recruit? Do people want to be part of the trial? Can we retain people on the trial? Do they find it acceptable, and are they able to stay on that trial? And the acceptability of it, so looking at the perceptions of taking part in the exoskeleton trial and any discomforts that they're experiencing. Our secondary outcome measures are around the intensity and volume of exercise that they're able to achieve, both within the standard exercise sessions, but also using the exoskeleton, because what we really want to see in the future is if they can exercise in intensity and duration that can benefit their health. So are they improving their fitness, health and quality of life by taking part? Now, this project was due to start at the start of COVID-19, so I thought it was worth sharing some of the challenges of this kind of research. So obviously in COVID-19, the exoskeleton intervention was going to take place indoors. It needed 2 people to walk with a vulnerable participant, which obviously wasn't going to happen for quite some time. We then had issues with equipment and technology. the technology had been standing during COVID-19, and despite servicing, could not be resurrected to a usable format. So we had to kind of make the decision as to were we going to really drive this project forward and find a new partner, or were we going to sort of stop it there. But we felt that it was a really important thing to try and do. We had people that were waiting to take part and really wanted to take part. So we'll look at where we're at in a moment on the next slide, but we're moving on with the trial. But these changes have obviously caused our own challenges with changing timelines and needing to make sure we've got facilities and staff available to still deliver a completely different time to when the project was planned for. And I think the other important thing to recognise is management of expectations of people taking part in the research. A lot of people view an exoskeleton as a bit of a silver bullet or a magic wand to being able to walk again. And for people that haven't been able to walk, this is really important and something that they really want to do. And it's really important to help people to understand that, you know, the exoskeleton isn't suitable for everyone. So you do need to have a certain amount of hip strength, a certain amount of upper body strength to be able to use it. It does require quite a lot of familiarization. And it's also expensive for personal use. So kind of beyond being part of a trial or using it in rehabilitation, it may not be necessarily available to everybody. So where we're at with the trial now, we have training lined up. I think it's later this week, Rachel. I think she's got that planned on the new exoskeleton. So thanks to Kyogo, who are going to be our new partner, who are loaning us their exoskeleton to finish this trial. And we hope to have some results to share by the end of this year. So thank you everyone for listening. I think we're back to Rachel.
Yeah, thank you, Anouska. I did have just one last slide to quickly share, but I'm also aware of time, so I'm wondering whether or not that can be circulated afterwards. And Nick, do you think if we go into Q&A now?
Yeah, that sounds like a great idea, Rachel. Thank you. We have had, well, first of all, thanks to all the speakers for a great session. But we have had one question in from Cheryl McBride, who is asking for your thoughts, and I'll open this out to all of you, or three of you, on this statement. So she's saying referrals onto some kind of third sector venues for exercise incur costs for the service user to access the facility, as well as transport costs, if the stroke survivor is able to leave their home. In the current economic climate, this can sometimes be perceived as a barrier to exercise. So what are your thoughts, any of you, around that?
Yeah, well, thank you, Cheryl, and hello, and thank you for joining the seminar this afternoon. That there has been a number of studies which has investigated the barriers to engagement with exercise amongst people with stroke, and that's included home-based exercise as well as venue-based exercise. So you're absolutely right. The key barriers which come up repeatedly in these studies, and this is on a global, not just a UK level, are transport, concerns about falling within the venue as well, concerns about the staff not knowing what to do, and also concerns about there not being appropriate equipment. But cost is a major factor. So, for example, there are some therapy centres that can offer transport, daycare, which will include exercise, it might include refreshments and a meal. But for that full package, you're looking at maybe £100 a day, which is prohibitive for most households. So cost is a big barrier, and transport are big barriers, but also fears about what might happen when I get there. And often if you look at a typical leisure centre, even just getting through the turnstile can present a challenge to people. So to be encouraged, I think there are some examples of really successful pathways within the UK where people do transition from NHS into very well subsidised exercise facilities where there's, for example, voluntary lift services. So volunteers who might be people in early retirement volunteer to drive people there and get past some of those transport barriers as well. So the solutions are out there, but implementing them is the next challenge, really.
Thanks very much, Rachel. Nik and Anouska, would you like to comment at all?
Well, I can only just feedback on something. I don't know if this is a best practice, but there's a local recumbent cycling scheme in Hillsborough that does pay for the first session, and I think it's difficult for them to obtain funding to do that for the foreseeable future, but at least getting the first session paid for might be overcome at least that motivational barrier. Obviously, it's not just about motivation, but it might be that they enjoy it that much that just having that nudge to get past the first session can facilitate that.
Thanks, Nick. Okay, with just 3 minutes to go, I think we'll draw the session to an end there. Just to reiterate my thanks to all the presenters today, particularly for the AWRC for hosting today's session. As I said at the start, it's the last in the current series of the seminars, but they will be restarting after the summer, so do watch out for those. They'll be as widely distributed as possible. So thank you all very much for attending, and we'll hopefully see you at the next one.